Good morning. I would like to start, first of all, to acknowledge Stefan Holliger, who did this work with me together with me. And I'm going to talk today about functional connectivity alterations in autism spectrum disorder. And I would like to start with background and the rationale for this work. And this slide illustrates a non-exhaustive literature overview of the last 10 years on functional connectivity in autism. And the key take-home message from the slide is actually that when we look closer to the studies, there's very little convergence with respect to the findings all the studies report. So some studies report a decrease in functional connectivity, some find there is an increase, and there are also quite a few studies finding a mixture of both phenotypes. And the commonality between those studies is actually that there is no commonality with respect to methodology they apply. So every single study used another metric of functional connectivity, but those studies also strongly vary with respect to diagnostic inclusion criteria and any other possible demographic variables. So we wanted to address that question in an exhaustive study where we collected 4 different data sets, public and non-public data sets, containing data from autistic patients and typically developing healthy controls. And these 4 data sets were as following. On the left side, you see the OHBM data set, a European prospective initiative, which collected in a prospective and standardized manner a large cohort of ASD patients and healthy controls, and with a standardized sequence, and it's also a multi-center study. And two other data sets are the ABITE-1 and ABITE-2 data sets, which are retrospectively pooled data from different researchers with highly heterogeneous populations, but also varying sequences and many other factors differing between those populations. And last but not least, we also had access to a single cohort from a single center, the info data set collected in Paris, where basically all subjects were scanned at the same scanner and using the same criteria. And basically what we wanted to do is we wanted to compare them in a more or less conservative manner. So we used the prospective cohort, the biggest cohort, as an exploration cohort. So we tested first for functional connectivity alterations in the OHBM data set. And then whatever came out of this data set, we tried to replicate in the other 3 cohorts. And to do this, we used a simple connectivity metric, which is called degree centrality, and the concept is illustrated on the right side. Basically, we just count the correlations above a specific threshold using some default parameters for that metric. And basically, if a voxel has many significant correlations with other voxels in the brain, it has a high degree centrality. And if a voxel is basically not correlated with anything else, it has a very low degree centrality. And so using this metric, we then went further and looked on what happens in the OHBM cohort. And indeed, we found 2 significant types of clusters. We found both regions of increased degree centrality, which is basically a frontoparietal network, and we found also regions of decreased degree centrality, primarily in sensory motor regions and also in temporal regions. So, and when we try to express it, like to see what kind of effects we are talking about. So we've also extracted the effect sizes for those regions, and it turns out basically that in particular the increased degree centrality had a kind of strong effect size, while the decreases were of a moderate effect size. So then we basically took these 2 types of clusters and created binary masks out of them, and extracted the degree centrality for the other 3 replication cohorts, basically in a prospective manner this way, and again compared ASD patients and healthy controls. And what we saw was basically that for the increases in degree centrality, in all 3 replication cohorts, we also had significant increases in degree centrality. However, when we basically expressed it again as an effect size, we saw that in both ABITE-1 and ABITE-2, which again, to remind you, are retrospectively established data, which are very, very heterogeneous, we saw substantial decreases in this effect size. So effect size was rather small. However, to our positive surprise, in this info data set, where we had basically a single site cohort, the effect size was actually even stronger than for our initial exploration data set, suggesting a very strong effect for this population. And similar results were also obtained for the decreased degree centrality, where we were able to replicate that finding in 2 out of 3 cohorts, with the exception of the ABITE-2, where this effect was absent, suggesting that there may be more behind that effect, and we need to study further additional characteristics to understand the lack of this effect in some of the cohorts. So having done that, we also said, okay, degree centrality is a pretty simple metric. So it tells us that there is a kind of connectivity alterations, but we don't yet know what is the underlying, basically, phenotype of this correlation. So we tried to compute different types of metrics based on those degree centrality masks we've obtained from the UAMs cohort. And we first of all, we looked, for example, does the mean connectivity within or outside of those regions, or from within to outside of those regions, differ between ASD patients and controls, and what are the effect sizes for that? We also tested the hypothesis that the variance in connectivity may be different. So basically that the ASD patients have many strong connections, but also many weak connections. And another two metrics where we also looked if it's not neither the mean nor the variance, but maybe the proportion of connections, because we applied a binary threshold, I've shown before. Because of the threshold, it may be that the proportion of connections exceeding this threshold is different between ASD patients and controls. And last but not least, we also looked if, as there is a shift in connectivity from outside of these networks to inside of these networks, or vice versa. So basically, that it's not really any kind of change in connectivity parameters, but maybe a change in topography of this connectivity system. So having done that, we basically expressed all of these different types of metrics, so mean, variance, proportion, and shift. We computed the effect sizes for differentiation between ASD patients and controls. And so on the right side here, this is basically the initial degree centrality finding. I will show it on this side. And those are the effect sizes obtained for the different metrics. And what you see here is quite strikingly is actually that for the increased degree centrality, it turned out that in particular the shift in connectivity basically was expressing the strongest effect size, actually even a stronger effect size than the initial degree centrality finding. And similarly for the decreases, we also saw decreased mean degree centrality, but we also saw that the shift was also similarly expressed. So there were several metrics differentiating between ASD and controls with respect to the decreased degree centrality. And in particular, those shifts in connectivity were very closely correlated with the initial degree centrality findings. So just to give you an illustration of what the shifts actually kind of represent visually. So basically, if we take this increased degree centrality and create out of them in the typically developing controls with a kind of inside mask and outside mask, and just look on the connections and then count them in the typically developing controls. So what you see in typically developing controls, that those regions which are so basically inside the network or outside of this network have a specific number of connections, and inside this network they have also a specific number of connections. However, when we look to ASD patients, we see that if you basically control that the number of connections outside of this network of regions to each other decreases in ASD patients, and those regions which are outside of this basically red one start to be more hypersynchronized with this frontoparietal network. So basically it's a desynchronization of regions outside of the frontoparietal network, and basically they synchronize them stronger with the frontoparietal network in ASD patients. So, okay, having basically made these conclusions or brought it to a bit more focused interpretations than the degree centrality, we then also tested various hypotheses. Is this type of alteration anyhow linked to any demographic, clinical, or any other potential confounding factors which were reported in the literature? And actually, we didn't find any consistent associations with age. So basically, this metric was driven by age, but it was not really differentially driven between patients and controls. So there was no difference between with this index in adolescents and children or adult ASD patients. We also didn't find any effects of medication, which would suggest that the medication drives these interactions. Actually, we found the opposite, that in the UAMs data set, the medication was rather diminishing the difference between healthy controls and patients, suggesting a kind of protective effect, more or less. And we also found that motion basically didn't really contribute to those effects. So we looked also on the group level, so motion wasn't, as reported in previous studies, different between ASD patients and controls. However, when we even looked on the group difference, does the motion explain those effects? We couldn't find any evidence for that. Controlling for motion actually improved these differences even further. And we also couldn't find any associations with sex for those indices. Importantly, we also then lastly tested, are those indices in the ASD population only anyhow linked to the clinical symptomatology? And we used here again a very similar exploration and validation approach, meaning we use the UIMS data set to identify significant relationships. We indeed found a linkage to cognitive and communication and social skills, and we could replicate that effect in the ABITE1, but not in the ABITE2 data set. So again, and coming to the conclusions, basically, indeed, we find reproducible hyperconnectivity in ASD, and those alterations are linked to clinical symptoms, but yet not consistently across different cohorts, and we need to further understand those discrepancies, and we couldn't find any evidence of confounds driving those effects as opposed to previous publications. So, and I would like to thank all the contributors to the study. Of course, there are quite a few of them because of the large effort, and to point you to the poster 1179, where we also explain those findings more in detail. Thank you very much.